Chapter 4 will allow us to review the drugs used in anesthesia. It comprises two sections, really. As far as anesthetics, the actual general anesthetics that are inhaled versus the ones that are IV. And then a lot of the other drugs that are necessary in the protocols of anesthesia, with an emphasis on skeletal muscle relaxation. As you look at general inhaled anesthetic, you're looking at the use of gases. Gases are administered through the lungs and then from lung tissue quickly achieve a specific concentration of anesthetic in the blood. This is what we would call, if you want, the blood anesthetic. That blood anesthetic is wonderful to have circulating in the body, but this is not because the drug is in the blood that it has any effect. As you know well, the anesthetic must leave the bloodstream, cross the blood-brain barrier, and get into the CNS in order to cause anesthesia. This is where the active form of the anesthetic must be. Now, like all drugs, gases are protein-bound. You may recall from your physiology that a gas such as oxygen is actually 99.7% bound to proteins such as hemoglobin, so that only 0.3% is actually the active fraction. It is a little bit the same thing here. Blood anesthetic will mean, if you want, the bound anesthetic to proteins, the portion that is too large to actually diffuse and get in the CNS. The free anesthetic is the one that would be active, and that's the one we're going to call the gas anesthetic. Well, we'll see that in pharmacokinetic, we're going to like to do what we call a blood-gas ratio. And a blood-to-gas ratio is literally looking at how much of the anesthetic is in the bound form versus how much is in the free form, readily accessing the CNS. Now, as a gas, it is very lipid soluble. And if being in the CNS is associated with the anesthesia, certainly being in the fat around your waist, your butt, or your breast is not going to cause any type of anesthesia whatsoever. We normally have much more fat in those locations than we do in the brain, or so we hope. And if this is the case, we know that then the distribution of the anesthetic will involve not only the CNS, but also the fat. If you remember well your general principle, there is a different chronology in reaching those two tissues. Because of high vascularization of the brain, the free anesthetic will very rapidly reach concentrations in the CNS that would be associated with the anesthetic effect. But just as rapidly, it will redistribute to lipid tissues. As it redistributes, it is a much slower process for the actual gas to build up in the fat, simply because of the different vascularization of that tissue. Nonetheless, we can expect that then on stopping the administration of an anesthetic, there might be residual effect of a medication, simply because as it has redistributed in the fat, it can just as well come back into the blood and go back into the brain. Well, various pharmacokinetic parameters are shown in the table, and there are only two inhaled anesthetic that are reviewed here. Nitrous oxide, to be opposed to the family of halothane. Halothane is a halogenated type of anesthetic, and if you look under the table, there are other halothane-like drugs that tend to end up in fluorane. For example, drugs like desflurane, sevoflurane, enflurane, methoxyflurane. Really, for all intents and purposes for the board question, if you realize that all of them are halothane-like except for nitrous oxide, you'd be really in good shape. Since here are the pharmacokinetic measurement, we like to look at MAC value. Underneath the table, you find text related to the MAC value. Let's look at it. MAC value stands for minimal alveolar concentration of the anesthetic. In effect, it's the concentration of inhaled anesthetic that would result in 50% of your patients to not respond to a surgical stimulus such as cutting with a scalpel. MAC is obviously a measure of potency as an ED50. It's the dose that is efficacious in 50% of the population. It is logical that the more lipid soluble the anesthetic, the greater the potency, and the greater the potency, the less I need in concentration of this anesthetic to achieve my anesthesia, so the lower the MAC. Well, if I look back then at this table, I notice a tremendous discrepancy between the MAC of nitrous oxide, 104% of inspired air to reach the ED50, versus that of halothane and other halogenated compound, which is less than 1%. Obviously, which drug is more potent? More potent would be drugs such as halothane. Nitrous oxide is the weakest of all these inhaled anesthetic. Other little points about MAC values. MAC values are additive. So as I use different formulations of anesthetic during my anesthesia protocol, they will all add up to the final end product, which is having a properly anesthetized patient. It is also relevant that, as for most drugs, MAC values are lower in the elderly. As such, we need to adjust the dose accordingly based on age. You know, some parameters such as clearance, such as volumes of distribution, metabolic rates, all these are classic changes that occur as we age, and they often require a downward adjustment in the dosages of medication. Otherwise, other CNS depressants have an additive effect to the CNS depression of anesthetics. This is why we tell you that MAC values will seem effectively lower in presence of opiates that might be used as central analgesic, or sedative hypnotics that might have been used for inducing anesthesia. So remember well for right now, MAC values are very different between nitrous oxide, the weakest, and halothane family, the more potent gases. Onto the blood-gas ratio. A blood-gas ratio is really a pharmacokinetic parameter to link to the first diagram we looked at. Blood is the bound anesthetic. Gas is the free anesthetic. Basically, as I'm doing a blood-to-gas ratio, I'm looking at how much of the drug is trapped in the blood on protein and how much of the drug is free and capable of going across the blood-brain barrier, causing anesthesia. What value would you like to have if you wanted to rapidly achieve free concentration of anesthetic in the brain of your patient? I'm sure you would like to have most of your drug as a free gas and as little as possible as a protein-bound gas. So what would happen to the ratio? The ratio would have to be as small as possible to allow you to have a rapid onset and then a rapid emergence of anesthesia. Let's look at this table again. The blood-gas ratio of nitrous oxide is much smaller than the blood-gas ratio of halothane and its family. You know what is meant by this is that nitrous oxide really is not very plasma protein bound. Most of it is a free gas, and most of it will rapidly reach significant CNS concentrations in the brain of your patient. Contrast, halothane is much highly protein bound. That is because it is more lipid soluble. That was also why it was more potent, by the way. And because it's more protein bound in the plasma, it'll take longer to achieve relevant CNS concentration. So maybe nitrous oxide is weak, but with a small blood-gas ratio, it affords a rapid onset and rapid recovery of the anesthesia. We're going to add to this for nitrous oxide another couple points of interest. For one, even though it's a strong CNS depressant, it does not have or has minimal cardiovascular suppressant effect. Cardiovascular function is always a worry in carrying out anesthesia protocols. Imagine this, if your patient had any cardiovascular type of disease, any risk for arrhythmia, using drugs that decrease electrical activity in the brain invariably would be expected to do so in heart tissues too. Well, here this is not the case. Actually, we're going to also add that nitrous oxide is not metabolized at all. So who cares about liver or kidney function? The drug comes in through the lungs by inhalation, and it will leave as is through the lung by exhalation. It means you have now a drug that has rapid kinetic, minimal cardiovascular effect, and no metabolism. You have there a drug that is potentially very weak, but excellent to use to induce anesthesia. Because it's weak, it would not be used alone to carry out a surgery. But certainly with kinetics such as those, it is a great tool to start the process of anesthesia. Remember, because also of these characteristics, nitrous oxide is even used in outpatient type of surgery and actually often used in dentistry. What would be some potential risk with nitrous oxide? Well, one risk that comes to mind is I had to use a lot of nitrous oxide to achieve some kind of anesthetic effect. Since it is breathed out, if I'm not careful in ventilating the patient or administering hyperbaric or more oxygen to that patient, it is possible that as nitrous oxide takes its room as a partial pressure of gas, it displaces that of oxygen. Remember Henry's law? You might have seen this in your respiratory physiology. Henry's law always states that the atmospheric pressure is the sum of the partial pressures of gases. You adding one gas here, which is an anesthetic, invariably, since the sum must still equal atmospheric pressure, it has to take on the concentration of other gases. This is what we call diffusional hypoxia. The fact that the patient might breathe in and out nitrous oxide rather than oxygen. Well, a slow termination of the anesthesia to nitrous oxide and the administration of oxygen can take care of this. What has to be a worry is the potential for spontaneous abortion when nitrous oxide is used. If you are about to use this drug in outpatient surgery, if it is a lady, you want to make sure that you know if she is pregnant or not. Nitrous oxide can trigger contractions. A final point not written here, nitrous oxide can be used at small dosages as a drug of abuse. It is actually often referred to as laughing gas. I often ask Kaplan to actually provide us with tanks of nitrous oxide, and sometimes it would be quite needed. But the idea is to take a CNS depressant at small doses, a little bit like we do alcohol, and as such get a disinhibition. As laughing gas, you could imagine maybe dentists or medical personnel who have easy access to this gas abusing this chemical. On to halothane and other enflurane, desflurane type of drugs. Well, they certainly are not innocuous to your cardiovascular system. For example, a drug like halothane can sensitize the heart to catecholamines. Sensitization to chemicals like norepi or epi can be associated then with cardiac arrhythmias. But I think by far you would agree with me that the biggest worry about drugs like halothane is the potential for malignant hypothermia. This is a topic that is always high yield for your exam, and we'll look at it when we see the drug succinylcholine in a few pages. So more to come on that story. Halothane, otherwise, and most halogenated compound, they will require metabolic routes to be set up in our liver. And halogens like fluor, like chlorine, like bromine, these are all halogens and they're very poorly metabolized in the liver. They tend to accumulate. As they do, they tend to cause damage. Halothane was well established as a drug causing cumulative hepatotoxicity. Thereby, one surgery using halothane would cause a certain amount of damage. A subsequent surgery, even months or years later, might add on and cause cumulative damage to the liver function of a patient. So certainly not the same profile as far as safety that nitrous oxide had. Besides talking about blood gas ratios with the table and the diagram above, you have a small summary here of what blood gas ratio refers to in terms of its effect on rate of onset and recovery. The more soluble the anesthetic is in the blood, the slower the anesthesia. If you want, as we said, the higher the plasma protein binding, the greater the fraction of the drug anesthetic is in the blood, the longer it will take to achieve adequate efficacious concentration in the brain. So that means anesthetic with high blood gas ratio like halothane have a slow onset. They also have a slow recovery. Anesthetic with low blood gas ratio like nitrous oxide, never forget, have fast onset and recovery. If gases are classically used in anesthesia protocols, so are IV anesthetics. And the first two you know well. Thiopental is a barbiturate that is ultra short-acting, used for induction. It is highly lipid soluble, and it's short-acting primarily because of redistribution. Midazolam was a benzodiazepine we used not only to induce anesthesia, but we used also for preoperative sedation, and don't forget, for the potential benefit of anterograde amnesia in a surgery patient. Both drugs would depress respiratory function, However, being that we have here an intubated patient who is mechanically ventilated, it should not be a worry. Tell me, if I use too much midazolam acutely, any antidote? I'm sure you're thinking indeed of the drug fumazanil. Contrast. Any antidote for thiopental? Don't scratch your head too long. We should well remember there are no antidotes to thiopental overdose. Here's two drugs that are quite relevant in anesthesia protocol for some unique point. Propofol on your USMLE step 1 will actually potentially be described as looking like milk. And if indeed you've seen it in our hospitals, it does look exactly like a glass of milk, totally white. This anesthetic that looks like milk has one important characteristic. It is antiemetic. We want an antiemetic effect, being that we want to not have to worry as readily of aspiration injury. Aspiration injury is a lung injury secondary to aspiration of stomach content. And gastric content being extremely acid, there is the potential for damaging the delicate structures of our alveolar septae. This would result in respiratory distress syndrome, which, as you know well, carries a mortality rate of about 30 or 40%. So as such, antiemetic are always welcome. Propofol has the advantage of duality. It is an inducer of anesthesia that is a strong antiemetic. How about fentanyl? Fentanyl, we're going to review, as we review morphine, the pharmacology of opiate in a subsequent chapter. Opiates have the advantage of not only being strong CNS depressant, they can actually noticeably depress respiratory function. Opiates are also central analgesics. Yes, this is something that has to be reminded to us here. Is anesthesia synonymous with analgesia? Obviously, if it were, we would not have two words, would we? Anesthesia just refers to the lack of responses of your patient when you try and arouse them. It does not necessarily mean that this patient does not feel pain. So most anesthetics cannot be used alone without the use of analgesics. Fentanyl is an anesthetic that is also an analgesic because it's an opiate. Well, more to come on this and its respiratory depression when we review the drug morphine. Finally, at the end of your page is the famous ketamine. I'm saying famous because over the nearly 20 years of reviewing board information for your USMLE, I have always heard of ketamine being a classic board question. Ketamine and all the points given here have been board points. It is a dissociative anesthetic, number one. Dissociative literally means that your brain is really not depressed. It's not like you totally passed out and won't remember anything. It's more that although the pain is occurring and you're aware of it, you literally don't care about it. You don't care about it because your brain no longer senses that pain is a negative stimulus, a nauseous stimulus. So what the heck, if they're cutting your arm off, well, you can just look at it and decide, oh wow, this is pretty strange and amazing. You might actually be dissociating enough with a drug like ketamine that you might feel those out-of-body experience. And your patient might think that they're literally floating above their body in the surgery room while things are going on to it. I'm sure you understand then why ketamine is a drug that is extremely famous for on emergence resulting in vivid hallucination, potentially vivid nightmares. It is actually a fact that ketamine is a hallucinogen. And as a hallucinogen, this is a drug that is actually an analog of, you know what drug of abuse? An analog of phencyclidine or angel dust. Phencyclidine, also known as PCP. So you can imagine, basically, we are shooting our patients with a hallucinogen when we use ketamine. It is known that its pharmacology is primarily that of NMDA receptor antagonism, amongst other pharmacology to cause hallucination. So that don't think that a drug like felbamate, that we saw as an anticonvulsant, would share all the effects of ketamine. But your boards like NMDA receptor antagonism for ketamine. as an inducer of anesthesia that causes vivid nightmares, particularly the night after the use of a drug, it has the notable point of not being cardiovascular depressant at all. As a matter of fact, it has a unique point of stimulating cardiovascular function. I'm sure many of you are already thinking or remembering how, yeah, I'm sure I would use ketamine then in an older patient with compromised cardiovascular function. That is a potential use indeed. Never use ketamine in people with neural type of trauma, since it is known to increase intracranial pressure and therefore worsen the risk of potential herniation. Now, ketamine is quite commonly used in children. And in children, we love to use ketamine as a dissociative anesthetic when we want to do things such as dressing burns or manipulating compound fractures in limbs of children. These are very painful manipulations, as you know well, and we don't need to have a patient anesthetized, intubated, and under life support for this. A drug like ketamine then becomes exquisite as a drug that causes dissociation.